common pathway of clot formation. We have, they asked for the common pathway, means related with factor 10. We know 10 is the common pathway, right? So how 10 is activated or how 10 is working? Where is 10? Here is 10. First, we need to make 10 active. How it will be active? Because when only X, it means it is inactive. It need to be activated. How? With the help of activated 5A. So activated factor 10 with the help of activated factor 5. So activated 10 with the help of activated 5 will transform from factor 2 prothrombin to thrombin. They will act on prothrombin to make it thrombin. Again, we repeat the same sentence. They asked about the common pathway of clot formation. Common pathway means it is 10. So 10, make it activated 10. Activated factor 10 with the help of activated 5.
Activated factor 5, we transform
prothrombin to thrombin.
to thrombin.
Okay. Now, thrombin has two functions. One, thrombin will hydrolyze fibrinogen to fibrin. This is one function. Thrombin, first it will do fibrinogen to fibrin. They mainly hydrolyze, means break down with water. Thrombin hydrolyze fibrinogen to fibrin. This is number one function. Number two, activated factor 13 to cross from linked fibrin clot. And number two, activates factor 13. Here is factor 13. This is 10, 11, 12, 13. It activates factor 13. Activates factor 13. Why? To cross-linked fibrin clot. To cross-link fibrin clot. To make a cross and link of the fibrin clot. So, again, activated factor 10, the help of activated 5, it works on prothrombin to form thrombin. Now, thrombin has two functions. One, thrombin hydrolyzes fibrinogen to fibrin, and thrombin activates factor 13 to cross-link fibrin clot. Okay, what is the common pathway of clot formation?
Activated factor 10 with the activated factor 10 with the help of activated factor 5 will convert prothrombin to thrombin, and then thrombin will hydrolyze fibrinogen to fibrin and activate factor 13 to
Cross-link.
Crosslink the fibrin.
Fibrin clot. Cross-link fibrin.
Fibrin clot.
Cross-link fibrin. Define thrombus. This is pure pathology.
Thrombus is product of clotting pathway formed from constituent of blood and remain it is the same position.
Three things. This thrombus. In general, we know thrombus can what?
Lies, is it?
There was difference between clot and thrombus, right? Clot remains in the same place, like hematoma or blood clot in the surgical site. Suppose tonsillectomy done, there is a clot formation over there, right? Clot remains within the surgical site in that place, but thrombus, it is like a droplet, like a lipid droplet or lipid small particle which can travel with the blood. That is why it is a product of clotting pathway formed from the constituents of blood, as like before, fibrin clot. How it was formed? It was formed by uh, clotting factors, platelate, fibrinogen, fibrin, then factor 13. All of these came. So these are the blood constituents or elements. So it is a product of clot formation or clotting pathway formed by the constituents of the blood and remains in its same position. So thrombus
So
is not
thrombus
going
is
anywhere.
a embolus will be
Embolus will be traveling.
is
Okay,
a
what is
product of
thrombus?
clotting pathway that form from constituent of blood and remain in same position. Thrombus and embolus. What is the difference?
Embolus can travel. Embolus can travel. There is thromboembolism, DVT. DVT happens because of embolus, but not from the thrombus. Mhm. You are checking difference between. If you get nice
Yeah,
picture
I'm
like the
checking.
previous one, that was the nice picture. Preload and afterload. Like that, if you get good. So thrombus is the product of clotting pathway which formed by the constituents of the blood and it remains in the same position. Oh my god, question number 21. What type of complication happen to non-displaced thrombus? Okay, it is not displaced. So what complication will come? It will be
Infection and
infection and
inflammation.
inflammation. Infection is formed here. What is thrombus? This is thrombus. See the picture. It is the product of clotting pathway, first criteria. Second, it formed by the constituents of the blood. Third criteria, it remains in the same position. So if it remains in the same position, what will happen? It will get infected
Inflammation
and
and
inflammation.
inflammation.
Infection and inflammation.
Like deep vein thrombosis.
Deep vein thrombosis. DVT is dangerous, right?
Yeah. Deep vein thrombosis, the fragment of the thrombus can embolus and lodge lead to the pulmonary embolism and etc.
Mhm. But they are traveling. See, when DVT, deep vein thrombosis, they are traveling and
The
they are going to the
deep,
even lungs.
deep vein thrombosis is thrombus. The one that traveling we call it embolus.
Hmm. But
Mm.
we mix the term together, thromboembolism.
Yeah,
But if we
thromboembolism.
say specifically embolism, like DVT, deep vein thrombosis.
Mm.
So here it is ultimately
Deep vein
is it a DVT?
deep vein thrombosis, yeah, is thrombus can lead to thromboembolic stroke.
So thrombus, it is dislodged and now it became a embolus.
Mm.
Okay. So what type of complication can non-displaced thrombus, a non-displaced thrombus can lead to
Infection and mm, infection and inflammation.
inflammation? What test you will do if you suspect that thrombus is infected? We will do CBC, inflammatory markers,
Um,
CRP-ASR, and blood culture.
and okay.
Real question. What is CRP? CRP is a
C-reactive protein
acute phase protein
is a acute
produced by the
phase reactant
hepatocyte.
produced by liver in response to inflammation.
I think cytokines if increase in Infection.
It's not infection, inflammation. It's acute phase protein produced by liver in response to inflammation. Any inflammation, burn, pancreatitis, septic shock will be increased. It's not specific. Hello, you there?
So CRP, we can say yes. CRP is acute phase protein which produces in liver hepatocyte in response to any inflammation, and it increases in infection, inflammation, trauma, or stress.
Post-op as well.
This is, yes, post-op as well.
What you
What
look for
you
in the
look
blood
for
culture?
in blood culture? Common organism like
Organism
Staph
like
aureus and
Staphylococcus
Staph
aureus,
epidermidis.
Staphylococcus epidemidis.
Common organism like Staphylococcus aureus, Staphylococcus aureus, and Staphylococcus epidermidis. Not epidermis, epidermidis. Staphylococcus aureus and Staphylococcus epidermidis.
And then HACCP group.
And HACCP group of organism. This all H for Haemophilus species, A for Agribacter species, C for Cardiobacterium, Haemophilus species, Actinobacter species, Cardiobacterium hominis, Cardiobacterium hominis. Again, Haemophilus species, Agribacter species, aggregative vector, agriculture,
Oh my God.
aggregative vector, Haemophilus species, aggregative vector species, and Cardiobacterium hominis. Cardiobacterium hominis. So Haemophilus group, aggregative vector species, aggregative vector. So bacteria which is related with the agricultural word, aggregative vector, and then which is related with cardio and their bacterium. So it is named cardiobacterium, and they remain in the home, so hominis. Cardiobacterium hominis, and remaining are easy. Echinella, Kingella, Echinella and Kingella. Echinella, Kingella. Again, Haemophilus species, aggregative bacterium,
aggregative vector species,
aggregative vector, and
Cardiobacterium hominis,
Cardiobacterium hominis, and Echinella, Kingella. Only Echinella is sufficient. Echinella cordens no need. Kingella species. So, from where is secreted CRP?
liver, hepatocyte.
Liver hepatocyte. What is the type of endocarditis that occur in adenocarcinoma?
Liebman sac endocarditis.
I remember someone told Liebman snacks endocarditis. Liebman snacks endocarditis. Liebman snacks endocarditis. Liebman Sachs, S-A-C-K-S, Sachs. Liebman Sachs endocarditis. How many questions are there? Oh my.
We need to
28.
a little bit faster. We in the station 1.
Okay. What is the
Symptomatic guideline? for the
Liebman
WAF
Sachs
disease.
endocarditis. What is the antibiotic guidelines for the patient with aortic stenosis? Two guidelines, nice guidelines. No antibiotic for major
Antibiotic is
procedure or if it is
no
like before.
antibiotic except for major procedure or highly infectious procedure like upper GI. In some guideline, no antibiotic at all.
Okay.
NICE guideline, no antibiotic except for major procedure or highly infected procedure like GI, upper GI.
What can you see in microscopically in infective endocarditis? Ashok's bodies.
Ashos body
Finish.
is a form of
No
granulomatous
need. No need.
inflammation.
No need.
No
Just
need.
answer it. Ashok's bodies. What can we say microscopically in infective endocarditis? Microscopically, we can see Ashok's bodies. What are the signs in the hand of infective endocarditis? We get
Osler
ocular
knot,
nodes,
genuine lesion,
generations,
splinter
splinter
hemorrhage,
hemorrhage, clubbing,
clubbing,
hmm,
and
generations, osler nodes. We can see osler nodes. Osler nodes is painful raised red lesion due to immunocomplex deposition. Osler node. Osler node. Genuine lesion. Osler node. Infective endocarditis, we can see Osler node that is painful raised red lesion due to immunocomplex deposition, Osler nodes, and genuine lesion. It is genuine is non-painful. Genuine non-painful nodular or macular red lesions due to specific emboli which deposit bacteria forming microabscess,
microabscess.
but it is non-painful. Splinter hemorrhage, tiny little blood clot under the nail
Under
and
nail.
clubbing. What is aortic sclerosis?
The WAF disease with insignificant gradient across the WAF that can progress to stenosis.
Yes, we read this on before.
Mm.
AV valve, atrioventricular valve disease with insignificant gradient across the valve can progress to stenosis. Insignificant gradient across the valve can progress to stenosis. Okay. Now, temporal arteritis or giant cell arteritis. 76-year-old female referred for temporal artery biopsy, presents with headache, scalp tenderness, upper limb stiffness, and transient loss of vision in one eye. Why biopsy taken?
To identify giant cell arteritis to confirm the diagnosis.
Okay. Why biopsy taken? To identify giant cell arteritis. Giant cell arteritis. Headache, scalp tenderness, upper limb stiffness, and transient loss of vision in one eye. Giant cell arteritis. What is giant cell arteritis?
Is a granulomatous inflammation of large and medium blood vessel of the head, mainly branch of external
External
carotid
carotid
artery.
artery. So, giant cell arteritis is a granulomatous inflammatory disease. Granulomatous inflammatory disease of the large and medium blood vessel of the head, mainly branches of the external carotid artery. It is a granulomatous inflammatory. It is a granulomatous inflammatory disease of the large and medium sized arteries, mainly in the head and the branches of the external carotid artery. What are the histological findings on biopsy of giant cell arteritis?
Intima thickening and internal elastic lamina fragmentation and infiltrate with T cell and macrophages and multinucleated giant cell. I hate pathology.
I
Oh my
I
god.
I can notice that you are not interested in studying. No problem.
I
After
hate
finishing, After finishing this session, we will go to
I don't
some
know how
procedure.
to study this thing, how to remember this thing. But then we
But
need to remember.
yeah, we
Okay.
need to remember and
In,
we need to finish. We will
intima
do it.
thickening.
See, it is very simple.
Intim.
We are reading what? Remember. Now we know the topic, we know everything. That is why it is system also written in the upper side. But in the STEM, I think only they will give this information. That 76-year-old female referred for temporal artery biopsy. Okay, this is our clue. If we get temporal artery biopsy, okay, then this is our diagnosis, temporal arteritis. Why biopsy taken? To identify giant cell. And then the next question, what is giant cell? Giant cell is a granulomatous inflammatory uh,
Of large and medium vessel.
disease of large and medium sized vessel, mainly in the branch of external carotid artery. Finish. Then, if we do biopsy, what we'll get? We will get certain things. It is very nice. First, see, we will get
Intima thickening.
intima. It will be thickened. Intima thickened, 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 thickened. So first criteria already we got. Large and medium sized artery intima usually it will be thin, but here it will be intimal thickening. So first we got intimal thickening. Then what will happen? Internal elastic
Uh,
lamina, it will be fragmented. Internal elastic lamina, internal elastic lamina, it will be fragmented here.
Fragmented.
Yes, internal elastic lamina, this all will
Internal.
be fragmented. So second point you got. One is intimal thickening. Second, internal elastic lamina fragmentation. And what will happen? They become weak. Wherever there is weakness, at least two cells will be invited there. Who are those two cells? One is T cell,
T cell.
because they will eat tea with the biscuit. That biscuit is the macrophage. T cell and macrophage. So where there is any weakness, these two are invited even without invitation. They come. One is macrophage, another one is T cell. T cell, they come as their routine work. It's like T cell lymphocyte from the immuno reaction, and the macrophage is the chronic inflammatory, and this is a chronic event, not acute disease. As like your today's exam question, they asked
Is
acute inflammation. In acute inflammation,
neutroph-
neutrophil will count, but in
neutrophil.
chronic, they don't need any invitation. Two things. One is macrophage, he will come and he will say, I'm the biscuit, so I need my tea. So T cell also will come. And ultimately, they form a multinucleated giant cell. Then it become like a zombie movie. Big. So finish. We will not forget it ever. But again, have to do it. So three things. Histological finding of the temporal arteritis. First, number one.
Intima thickening.
Number two,
Internal elastic
lamina fragmentation,
lamina fragmentation, T cell, and macrophages
infiltration,
infiltration,
and formation of
and then formation of giant cell, granulomatous
multinucleated. Formation of
multinucleated,
multinucleated giant cell.
multinucleated giant cell. Okay.
Then what is the cause of loss of vision? Because they involve the ophthalmic artery and it is the nth artery. So there is
By
no
the
branching, no
inflammation.
supply and loss of blood supply of retinal artery, because involvement of the ophthalmic artery, which keeps central retinal artery, and this retinal artery is the end artery. So you got the point? Why blurring of
Yeah,
loss
yeah.
of vision? Because central retinal artery have been damaged, because it comes from ophthalmic artery, and this temporal arteritis involve the branches of the external carotid artery, and uh, uh, ophthalmic artery is the
Because
branch of
branches of external carotid,
no no no
internal carotid,
internal carotid. Yes,
the first branch of internal
internal
carotid
carotid artery.
ophthalmic artery.
Mhm. They said mainly they involve the external carotid, but
Loss of vision because it's involved the ophthalmic artery. The patient have loss of vision, it involve ophthalmic artery. It's not just temporal arteritis something. Yeah.
so it is the
Yeah.
answer because of involvement of the
Mm.
ophthalmic artery, which keeps the central retinal
If
artery, which is the end artery. Mention simple blood test would be used. We can do
erythrocyte
ESR and
sedimentation
CRP.
rate, CRP, ESR and CRP. So treatment usually by corticosteroid.
Hmm?
Treatment usually by corticosteroid. So how is treated? Is treated by giving high dose corticosteroid or methotrexate. Yeah?
Hello. So mention the simple blood test we can do. That is ESR and CRP. How this is treated means
Mainly by
temporal arteritis.
corticosteroid.
Mainly by corticosteroid.
Uh, give prednisolone 60 milligram per day per oral immediately, or IV methylprednisolone 80 milligram if involving visual loss or history of MRCS-Pathology. And then typically patient need to be on steroid for 2 years.
So treatment of temporal arteritis, we start with prednisolone 80 milligram, 60 milligram per orally immediately. Prednisolone 60
High
milligram,
dose.
60 milligram per day immediately. Or if patient comes with some complication like visual loss, history of amorous fugus, I don't know what is this, amaurosis fugus, then we start with 80 milligram IV and we continue it for 2 years. Because of this long-term steroid, patient will develop some other complication.
Yeah, is 60 milligram is high dose. Very high.
Very high. Usually we start with 5 milligram, then 10 milligram. For rheumatoid arthritis, it works nicely. Rheumatoid.
Please